Hello and welcome to the channel. Well, this video is mainly intended for eye surgeons, and I would strongly advise via discretion for all the surgical video presentations on this channel. This is Dr. Prashant Shukla, and today I am here with a very interesting case of a soft cataract. The nucleus grade in this case is about NS2 plus with substantial amount of posterior subcapsular elements. The surgery has been started. By this time one side port has been made. The anterior chamber is filled up with trypan blue. After stirring the anterior capsule, the dye is washed out using saline. Anterior chamber has been filled up with viscoelastic. In this case, I had few problems cracking the nucleus, so I'll just demonstrate how to finish the case. Main 2.8 millimeters phaco incision, a triplanar, is done using a steel keratome. The rexus is started using a bend needle cystitome. A flap is raised and the flap is then everted, and gradually the flap is moved in a circular motion. There was some visco leak, so I instilled some more viscoelastic and then took a forceps. The capsule is grabbed at multiple places and a rexus of about 5.5 millimeters, well centered, is created. Now is the time to do hydrodissection. The 27 gauge cannula is slid under the anterior capsular margin. The margin is slightly lifted up and small amount of fluid is passed across. In this case, I have done hydrodelamination also. With the same hydrodissection cannula, the nucleus is confirmed that it is rotating. For any cataract, one has to have a proper movement of the nucleus. It should spin well. Here I am doing a stop and chop technique. A long thin trench is made. The vacuum being used is about 70. This is a 2.2 tip, and gradual small long trench is made. After reaching sufficient depth, one has to be careful while making tunnel long trench in soft cataract, because one can easily go through and through. Got two heminuclei, and now switching to the chop mode. I am trying to bury the tip into the substance of the nucleus, but somehow there is a lot of surge, there is a lot of chamber fluctuations with the machine, so I have reduced the vacuum, the holding about 250. Previously it was 350. Still the nucleus is pretty soft and I am not able to get a hold of the heminuclei, so I am rotating and getting the heminuclei in front of the phaco tip. Again I am trying to hold the nucleus at another place. Still there is not good purchase, because the nucleus just crumbles in front of the phaco tip. So now I am going to switch to the mechanical fracture using the same Sinski and the phaco tip. I'll be trying at multiple places before I could get a small piece out of it. Here I am not using any vacuum, only foot pedal 1 is pressed, just the irrigation. The nucleus is just supported with the phaco tip at the border, and the Sinski will be then used to have a mechanical crack. Although in one heminuclei I got a crack, but it is not through and through. Again trying in the other, and yes, here I got a pie shaped small nuclear fragment which will be just emulsified in a second. The mechanical fracture or mechanical chopping is a good technique when we have soft nucleus which are difficult to hold. In this case, you don't need any phaco power or vacuum, just the irrigation thing can do. The other small pie shaped nuclear fragment is then emulsified. Again, the heminucleus is rotated. Here I got some crack, so I am going to just propagate that crack only. Yes, I could have a good crack, and both these small pieces will be just emulsified without any problem. For performing mechanical chop for early new surgeons who don't have much good control of the foot switch, one can just switch to continuous irrigation mode on the machine and just remove the foot pedal, and after having a crack they can just press the foot pedal to position 2 or 3 and just emulsify the small pieces. The nucleus can be seen, it is very soft, and the size of the nucleus is also very small. We could see a post-occlusion surge. Still the vacuum is very less. The bottle height I have increased. I have reduced the vacuum to about 150. Again I could have some post-occlusion surge. Reduce the vacuum to another less 50. Now the vacuum was 100, and the last piece could be just emulsified very safely. Whenever we have a surge in the machine, so it's always a good idea to increase the bottle height and increase the aspiration flow rate. This is a Venturi based system, so aspiration flow rate is managed automatically by the machine. So here I have reduced the vacuum and reducing the vacuum to about 150. Although things become slow, but they become safe. I am removing the epinucleus with the setting of about 150. Slowly and surely all the epinucleus is now been removed. Now is the time to remove the cortical matter from the capsular bag, and I am using a coaxial IA handpiece. A small nuclear piece just got stuck at the port, which is then gradually removed using a Sinski. Here I am using vacuum of about 250. Things go really slow, but they become safe. Once we have a chamber fluctuation during the surgery, it's always a good idea to work with low vacuum, and things are moving pretty fine with a low vacuum surgery also. Now all the cortical matter is now being removed, and now is the time to implant the intraocular lens. For this patient I have selected a preloaded single piece hydrophobic a spheric lens from Apaswamy Associates. Well, no financial interest though, but it's a very good lens and can be tried. The preloaded system in this lens is very good. Just fill in some visco in the cartridge and that's it. The lens is ready to be delivered into the eye. One haptic goes straight into the capsular bag and using the same Sinski hook, the other haptic is also dialed into the capsular bag and the lens is moved in the proper orientation. Now is the time to remove the viscoelastic. A thorough removal of the viscoelastic is necessary because we don't want any post-operative intraocular pressure spikes. First, the viscoelastic is being removed from behind the intraocular lens. And then the viscoelastic is being removed from in front and from the anterior chamber. Slightly it's cumbersome to remove viscoelastic with these hydrophobic lenses because much of the HPMC just gets stuck to the intraocular lens, which is not the case with hydrophilic lenses. Still, hydrophobic lenses are better than hydrophilic, so I would prefer a good hydrophobic lens for all my patients. After removing the viscoelastic from both behind and in front, the centration of the lens is confirmed and we have got a very good 360-degree cover of the anterior capsular margin. The lens is well supported in this case. Case is done. The main port is now being hydrated. Hope do you like the video. Please do like, share and subscribe to my channel. The side port is now being hydrated. The cornea is well clear. All the incisions are well closed. We should take a bit of time to close all the wounds properly. Also, just check for any fibers or anything which might be stuck in the side port, because these small cotton fibers, they usually many a times present in the post-operative period and they are also a potential source of infection. So just have a look. Yes, eye is quiet. That's it. Well, thank you so much and hope this video is going to help you. Some intracameral moxifloxacin for prophylaxis has now been given. The patient did well, and for more such videos, keep following the channel. Thank you so much.